Good morning, Facebook community, and welcome back to UCI Mind's monthly Facebook Live series, Ask the Doc, Alzheimer's Research Today. I'm Chelsea Cox, Associate Director of Education for UCI Mind, which is one of 32 Alzheimer's disease research centers funded by the National Institutes of Health. We're one of 32 across the country and the only center right here in Orange County. Here on UCI's campus, we are a collaboration of over 100 faculty, staff, and trainees who are dedicated to researching Alzheimer's disease and related disorders and solving them so that one day we can have a world without Alzheimer's disease. In this Facebook Live series, we aim to bring our experts to you to answer your questions about the latest advances in research. Today is episode 9 of our series, and I'm very excited to be joined by UCI Mind's Senior Neuropsychologist, Dr. Malcolm Dick. Thank you for joining us today.
Good morning.
Today, Dr. Dick will answer questions and discuss when it's time to see a doctor about memory concerns. And before we get started and delve into some of those questions, I'd like to just introduce Dr. Dick. He has been an Alzheimer's disease researcher and clinician at UCI since receiving his doctorate from University of South Carolina in 1984. So he's been here and practicing a very long time and is a real wealth of knowledge. And he is a highly respected neuropsychologist among not only the patients and families he serves, but the colleagues who he works with as well. Throughout his tenure here at UCI, he has been a part of 24 clinical trials. He's mentored 54 trainees. He has presented hundreds of community and professional lectures, and he's published numerous journal articles and book chapters. And Dr. Dick has really dedicated his life's work to improving understanding and diagnosis of Alzheimer's disease and related disorders. And so I'm very honored to have him here today to answer questions from the community. And welcome to all of you who are attending live today. If this is your first time joining us, just here's a little bit how it works. So I will get started by asking Dr. Dick a few questions to get us warmed up. And then as you have questions that come up, we encourage you to type them in the comments box, and Dr. Dick will answer as many questions as he has time for. But please do remember that whatever you type in the comments box is going to be visible to others, as well as linked to your name. And today, the purpose of this series is not to diagnose or advise on treatments. Dr. Dick is not able to answer personal questions about diagnosis and treatment. So please do try to keep your questions as general and relatable to the attendees as possible. Okay, so let's go ahead and get started.
Okay.
Dr. Dick, first, I would love it if you could provide us with some examples of what the differences are between normal versus not normal signs of aging and brain aging.
Okay. Certainly, and thank you for joining us out there. I get that question a lot in terms of the families that we deal with at our clinic and also when we do community presentations. And I think one way to describe sort of what is normal memory loss versus what would raise a red flag for us is to think about sort of how a person could progress from the normal age-related changes to, if they do progress, to dementia. And so I think it's often helpful for individuals to know sort of the stages that an individual could progress through. So as we all age, there's changes that happen in our body. We develop creaky knees, we have wrinkles, we lose height. So those are just normal age-related changes, and the brain also goes through these age-related normal changes. So the brain of someone who's 25 looks a lot different than someone who's healthy at age 85. So there's some shrinkage in the brain, there's some shrinkage in particular areas of the brain related to memory, like the hippocampus. There's also changes in blood flow and changes in certain nutrients and glucose utilization. So as we age, we not only have these physical changes, but our brain also undergoes some changes, and that produces certain symptoms, which we call age-related memory changes. And if you think about the kinds of things all of us pretty much experience, are things like where we'll temporarily block on someone's name. Mm-hmm. Or if we're giving directions how to get to a location, we might be very familiar with the streets, but we'll block on the name of a street. We also, as we get older, we start to have more difficulty learning new information. So when we're young, we maybe could read something one time and grasp the details. But now, as we get older, we have to read it multiple times. Okay. We're also more susceptible to distraction. So before, you could read something and you could have the TV on in the background. And now, as you're an older adult, you have to have quiet. Mm-hmm. So increased distractibility, slower learning, temporary memory lapses. They're not really forgetting, because often if you give the person time, the information, the name or the street name will come back to you. So those are some of the common changes we see in normal aging. Now, some of those individuals, and I believe some of your previous speakers have mentioned the main abnormal pathology of Alzheimer's, amyloid plaques and tangles. Now, in an individual where those are starting to develop in the brain, they may go into the second phase or second stage. And this is often referred to as subjective cognitive decline. And subjective cognitive decline, even though it's a new term, it has a long history of use, or a long history in sort of the psychological medical field. Back in the 1960s, it used to be called benign senescent forgetfulness. And then it's gone through various different names, questionable cognitive impairment. But I think generally now it's called subjective cognitive decline. And this is something that affects probably about 1 in 9 individuals over age 45. Okay. And what it is essentially where the individual has the subjective feeling that they're having some problems with their memory. And this is not the sort of age-related typical problems where you'll temporarily block on a name, or you go into a room and forget why you went into the room. This is a little more than that. This is where they maybe are forgetting procedures or tasks that they used to do quite well, but now they're having trouble figuring out how to do them. So it's a little more noticeable to that individual than sort of the typical lapses. And subjective cognitive decline could be due to a wide variety of different causes. Everything from depression, stress, metabolic changes like B12 deficiency. It could be due to head injury. Just about anything that affects the brain could produce this sort of subjective cognitive decline. Now, the word subjective is important here because not other people see it. Okay. It's something that the individual is experiencing, but maybe others have no idea. And it could be due to a wide variety of causes. Many people, probably half of the people that have subjective cognitive decline, will not progress. They may just stay the same, or they may get better. Okay. And particularly if it's due to something like anxiety, depression, sleeping disorders, if those are treated, it will go away. Now, some individuals will progress, and the third stage that they go to is called mild cognitive impairment. And mild cognitive impairment affects people in their 60s, maybe about 7%. You get up into your mid-80s, it's now somewhere between 25 and 33%. But mild cognitive impairment differs from subjective cognitive decline in the sense that now it's no longer subjective. Other people are noticing this change. Okay. And it's really becoming obvious. And technically, when we're doing neuropsychological assessments, an individual in mild cognitive impairment is now, in terms of their performance compared to their peers, they're usually scoring about in the bottom 10%, or about 1.5 standard deviations below what we would expect to see for somebody of their age and educational background. So this is where the memory problem is much more noticeable, both to the person and to others.
Okay.
So this could be where they're forgetting important appointments, doctor's appointments. They're forgetting how they got to their dentist's office, even though they've gone there, same office for the last 20 years. They're forgetting important parts of conversations, or the children will notice, well, you know, mom or dad are repeating themselves very often with even a short span of time. They could also have other cognitive deficits besides memory. They could be having difficulty with word finding. They could be getting lost, as I mentioned.
Mm-hmm.
They often will have what are called executive deficits, and these are things that affect planning, organization, ability to multitask. So mild cognitive impairment is sort of the first really stage where it's what is going on in the brain is really starting to impact the person's cognitive abilities.
Okay.
And also you can see changes in things such as motor speed. So individuals at this stage may be walking slower than they used to. There's also a lot of behavioral changes. In fact, there's a term, mild behavioral impairment, or MBI, that often occurs with mild cognitive impairment, MCI. And the mild behavioral impairment is where there's a noticeable change in behavior, but there's really not an obvious cause.
Okay.
So in our clinic, we've had individuals who have been normal for all of the years we've been following them, and then they'll start to develop, say, unusual preoccupations, or they may start to develop unusual beliefs, systems, or delusions. And it could be that this is the beginning of this mild behavioral impairment that could lead or be co-occurring with mild cognitive impairment. What happens to people with mild cognitive impairment? Well, about half of the people will progress to the next stage. About a third, 34% or so, will stay the same. They'll be stable for a number of years. And a small number, about 16%, actually will return back to normal.
Okay.
And it relates to what is the cause.
Mm-hmm.
Because there can be many causes of MCI, just like there can be many causes of subjective cognitive decline.
Okay.
If you go into the last stage, now this is the dementia stage. And the difference between mild cognitive impairment and dementia is, in both cases, the deficits in our thinking abilities are obvious. So they're often going to be scoring in the bottom 10 or 5% in a mild dementia on cognitive tests. The difference between MCI and dementia is now in dementia, the person's ability to function is compromised.
Okay.
So in mild cognitive impairment, the individual is now obviously forgetful or having word finding problems or maybe getting lost, but they're still able to function relatively well in most day-to-day activities.
Okay.
In a dementia, that's no longer the case. So in MCI, the patient who's always done his bills, for example, when he was in the normal aging or subjective cognitive decline, it would take him 2 hours on the weekends to go through his bills and balance his checkbook. In mild cognitive impairment, he still does it, but he does it less efficiently.
Okay.
So instead of taking 2 hours, he can do it, but it takes him 4 hours. In dementia, he's no longer able to do the bills.
Okay.
Maybe the family have taken that over for him. So in a dementia, this is where we start to see problems such as with driving, financial management. Word finding now is not just sort of an occasional word loss, but it's where it's starting to affect their ability to communicate with other people. They're having difficulty naming objects. So there's a lot of functional deficits, and as you go from mild to moderate and severe, the functional abilities, they become progressively worse. So in mild dementia, the person is having difficulty doing these higher level skills: driving, shopping, paying bills, operating appliances. In a moderate, now you're starting to see not only can they not do those higher level or instrumental activities, but now they're having difficulty with their basic personal care, like dressing and grooming. And then in the severe dementia, the individual is pretty much totally dependent on all functional abilities. So I think as an individual goes through these stages, we see different symptoms, and the severity of the symptoms gets worse.
Okay. So it sounds like it's kind of a long progression, and at what point, I guess, if a person is starting to experience some of those subjective memory concerns that you were referring to, what actions should they take? What should they do?
Well, that's a good question. If the individual is concerned about their memory, I think, and this is something that they're again noticing, maybe not other people, but I think it would be a good idea just to talk to their physician about it.
Okay.
I mentioned that subjective cognitive decline affects about 1 out of every 9 individuals. But interestingly, the research suggests over half of those individuals have not talked to their doctor about it. Mild cognitive impairment and subjective cognitive decline can be due to a wide variety of different causes. And many of those causes are actually treatable.
Okay. I think you mentioned some of them earlier.
Things like depression, anxiety, stress, sleeping disorders, metabolic problems such as thyroid, vitamin B12, folate deficiencies. And what a doctor would do is essentially, if you talk with the professional about that, they would probably refer you for lab tests. They would probably want to do an interview with you about your medical conditions, trying to determine what might be the cause. So I think in normal aging, we have these memory lapses, but if something is becoming concerning to the individual, and it's becoming much higher in terms of frequency of maybe forgetfulness or lapses, then I think it's a good idea to not ignore it, because many of the causes are treatable, but to maybe consult with your primary care doctor. They may say, well, why don't we refer you to other specialists, a neurologist, a neuropsychologist, a geriatrician, who could then do some testing and determine how severe is the problem, and also what might be the cause.
Okay. Now, there's some places that are offering, I've noticed out in the community, these free drop-in memory screening for older adults who have subjective memory complaints. I'm curious, what are your thoughts on this practice?
Well, as you mentioned, I've been at UCI a long time. So I have actually seen over these 30 plus years a lot of memory screenings. And, I think when you see a memory screening, you should probably ask a number of questions. But like, for example, why is this memory screening being given? There's places that can actually do a very good memory screenings, and there's other places where the memory screening purpose is to bring in customers. like they might do it at a residential facility or a senior health fair. And so why is it being given? The American Academy of Neurology in September of this year, they actually advocated that all individuals over age 65 should get some kind of cognitive assessment.
Okay.
And so this was a big step for the American Academy of Neurology to make that, because previously other organizations such as the U.S. Preventative Services Task Force, which has been around since the 1980s or earlier, which is made up of experts, and they're looking at evidence-based medicine. They had come out a year or so before saying they couldn't really advocate for cognitive screening. And they based that on the fact that they didn't think it was not helpful, but they didn't think it was enough evidence to show its benefits. The American Academy of Neurology proposed that this should be now something that all physicians do.
Okay. All primary care physicians.
All primary care physicians. So I think if the memory screening is done by a physician or a reliable organization like the Alzheimer's Association, I think you're probably going to see better quality assessment. So you have to look at why is it being given. You also need to look at who is it being given to and who's involved.
Mm-hmm.
So is it your primary care physician doing the assessment, or is it somebody who has very minimal training who is just asking questions at a health fair?
Mm-hmm.
So who's doing it is important, because you need to interpret what the results are. Also, who is involved in the memory screening? So is it just the individual, or more importantly, and of high value to clinicians, is to have an informant. An informant could be the spouse, it could be a family member, somebody who knows the individual well. So having that collateral source of information is very valuable. And I've seen some memory screenings where they'll just do a very simple test, draw a clock, and then give an interpretation based on that without getting any information from a collateral source about, is this person having any problems? Mm. So who's doing the testing, their qualifications, who's involved? Is it just the patient, or is it someone who knows the patient well and can answer questions? And then also you need to look at what type of tool is being given. Memory screening tools, there's probably half a dozen or more of them, but they vary in their level of complexity. Mm-hmm. And some of these tools are very simple, like drawing a clock. And others, like the mini mental state exam or the Montreal Cognitive Assessment, those maybe take 10 to 15 minutes to do, and they assess a lot of different areas, such as memory, orientation, language, some executive skills. Those take a bit longer than other ones. So what kind of test is being given is important.
Okay.
Interestingly, there was a study done, I think about a year or more ago in the United Kingdom, where they had a large sample of older adults, and some of them were normal and some were cognitively impaired with dementia. And they gave them 3 different memory screening tests. And one of them was the mini mental state exam that looks at orientation, some language and memory. One was called the memory impairment screen, which is just primarily drawing a clock and 3-word memory test. And then the other was a language one, looking at animal fluency.
Okay.
And they looked at how good were these 3 tests at distinguishing the 2 groups, demented versus normal. And what they found is that any one test, there was about a 37% misclassification. So that means some people who were normal adults were misclassified as being demented. And some of the demented patients were misclassified as being, quote, normal. So any one of those tests could have a high misclassification. Now you added 2 tests together, the misclassification dropped down to around 14, 15%.
Okay.
You added 3 tests altogether, the misclassification rate dropped down to around 2%. So what that tells you is that the number of misclassifications, or the accuracy of your diagnosis, or your saying this is impaired versus not, is dependent on the amount of questions and tasks you do. The more tasks you do, the more reliable your screening is going to be.
Okay, so using multiple tools and looking at it from different angles.
That's going to give you much more accuracy. And they also found the same thing I had mentioned just a moment ago, that when you took into account the comments of the informant or the caregiver, the spouse, the family, the accuracy of the classification diagnosis went up.
Oh, okay. All right, so that's important too.
So I think looking at these memory screenings, you need to ask those questions of, well, why is it given, the purpose, who's giving it, who's involved, and what kind of tool are they using, and who's going to interpret that.
Yeah. Okay, well, that's very valuable information. We just have a few more questions, so I want to turn to one of the questions, and it's related to what we were talking about brief cognitive screens. This viewer was asking if you personally are in favor of brief cognitive screens for all individuals at a certain age. Now, you recommended that, or you mentioned that it's recommended that for all older adults 65 and older that they do undergo screening. What is that the right age, do you think? Do you think it's the right decision? What are your thoughts on that?
Well, that's a good question, and I think you'd probably get different answers from different individuals. So I think one of the important points that we've developed over time is it is important to identify a problem early. And so I generally would be in favor of screening.
Okay.
I think prior to the annual wellness checkup that came into play a number of years ago, many doctors were missing individuals who had cognitive impairment. In fact, some of the research that came out of just looking at ER doctors and primary care doctors showed a very high rate of not identifying problems. It was only like 9 out of 10 physicians would miss MCI, and about 6 out of 10 physicians would miss even mild dementia. So I think having some kind of assessment is going to be useful, because we will identify a problem earlier, and that will lead to individuals getting access to treatment and being able to make plans earlier than that would normally, where they only might go to the doctor once things become very noticeable to the family as well as the individual. And as I've talked and we've mentioned, there's many things that can be done for individuals at the early stages, even if it's just relieving their anxiety that, well, you know, you have subjective cognitive decline, and we think it is due to the level of stress you're experiencing, or it's due to the fact that you have an undiagnosed sleep disorder. Or you have a vitamin B12 deficiency. We did some blood work and this is the cause. That can be very relieving to the individual. So I generally am in favor, but I would take that caveat of you need to also look at what kind of tools are being used.
And the person
administering it, and what kind of knowledge do they have.
Sure. Well, thank you. Unfortunately, that's all the time that we have for today. I want to thank all of the viewers who attended live, and especially thanks to Dr. Dick for joining and answering some questions. If you have more questions for Dr. Dick, he will actually be a panelist on our this Monday, October 7th. We have an in-person Ask the Doc panel where the community can come and ask questions of our docs similar to these and more. So join us on October 7th in the evening at the Fullerton Public Library. We also have our 30th annual Southern California Alzheimer's Disease Research Conference coming up on October 25th. Registration is open, and we are still accepting registrations for that conference, so we hope that you'll be able to attend and learn about the latest advances in Alzheimer's research. And if you'd like to participate in research at UCI, there's something called the UC Irvine Consent to Contact, or C2C registry, which is an online tool where you can go and fill out some information and possibly be matched with studies at UCI that you might be eligible for, and help researchers answer some questions, important questions about brain aging and other medical health information. And I also just want to mention that we hope you will join us next month. Again, this series is the first Friday of every month. So next Friday will be November 1st, and I will be joined by Dr. Maria Carrata, who is the co-principal investigator of the world-famous 90+ study. So she'll be answering questions and talking about her research in that area. So thank you for attending. Thank you, Dr. Dick.
You're very welcome.
And we hope to see you next time. Take care.